Hello, everyone. Warm welcome to all of us, all of you joining us from all over the world. My name is Saad. I'm a medical doctor, originally from Morocco, currently in France, and I'm proud and happy to moderate this follow-up session of the Illuminating series presented by Dr. Karim Qayumi about learning in healthcare education. I would like to announce that all previous episodes are recorded and are now available on the Cyber Patient platform within the Educational Resources module. As you know, the Cyber Patient Expert Series is an ongoing collection of webinars consisting of highly yield topics given by a wide variety of healthcare professionals. The goal of these series is to bring together students and faculty to directly engage with these experts, build connection, and support the future of medical education. This session is a follow-up of the 4 episodes of the Learning in Healthcare Education series. The aim of these events was to bring the learners, the educators, and share and challenge ideas and perspectives on fundamental theories behind education. In the previous sessions, Dr. Qayumi introduced us to the basic theories behind education and learning, to the frameworks of competency-based education, and how we can design a curriculum that answers to the changing needs of society and students. And the last and 4th episode was about gamification in education. I'm now going to present Dr. Karim, who's our esteemed guest for tonight. Dr. Qayumi boasts 50 years of teaching experience and is an award-winning innovator, entrepreneur, and teacher. He has achieved many accomplishments as a director of research for cardiovascular surgery, founder and director of the Center of Excellence for Simulation Education and Innovation at the University of British Columbia. He's also the chair of Technology-Enabled Learning and the regional director for the Royal College of Physicians and Surgeons of Canada. Dr. Qayumi is also the founder and CEO of Can Health International, a charity that aims to equalize health education between developing and developed countries. And of course, he's our beloved CEO and founder of Cyber Patient. Dr. Qayumi, you have the floor.
Thank you very much. I think it's very difficult for me to say anything about greeting because some of you are in Asia, some of you are in Europe, some of you are in South America. So the time is very different. I cannot say good morning or goodbye or good evening or good afternoon because it would not apply to some of you, whatever I say. So therefore I say hello, just hello. And I hope you accept my simple greeting. First of all, I would like to cordially thank every one of you for participating and expressing your interest, not only for the lectures, expert series, but also to ask specifically for this question and answer period so that we can help you, if possible, to unlock maybe some of the questions that you have in your mind. To start with your permission, I didn't make any slides because you have to ask me and I have to answer the question. But just to remind you what we have been through, maybe I will take a few times to do that. Can I share the screen now? Good. I have to share the screen before I open this, right? Okay. Okay. Now, Okay. So as you mentioned, it is a Q&A for this lecture series that I presented it. And if you remember, in the first lecture, we looked at the uh, foundation theories behind education. And the learning objectives were described at that time. And if you remember, we were talking about understanding the basic concepts of education. And we look at educational philosophies such as behaviorism. If you remember, Ivan Petrovich Pavlov in Skinner, in Watson, and others. We talked about cognitive theory, and we discussed Gestalt theory there, and we also talked about the constructivism theory of Piaget, a Swiss genius, and social constructivism theory of Vygotsky. We also talk about what are the issues behind clinical decision making, in order to understand the philosophical aspects of clinical decision making. We start talking about different type of thinking, dispersed thinking, reduced thinking, elaborated thinking, and compiled thinking. And to just remind you, the most important part for medical students and residency training program is elaborated thinking that is based on deductive reasoning. But when the students are finishing medical school and they go to work, after 5 years of practice, they switch into compiled thinking, which is based on recall, recognition, memory. The recall, recognition, memory supports the transfer of learning. And if you remember, we were talking about the difference between transfer of knowledge and transfer of learning. Because transfer of knowledge is from one person to another person, from one individual to another individual, while transfer of learning is from the same person to the same person. When dissemination of information goes from the same person to the same person. What it means is that how our prior experience affect our future experience. And we also talked about the Chan's description of the stages of cognitive transfer into the 4 stages, if you remember, because it is very important to remember. And the first stage was orientation, the second stage was coaching, the third stage was fine-tuning, and the fourth stage was routinization or mastery. So all these 4 stages you have to go through in order to transfer your past experience into the future experience. So that you remember the neurons, synaptics that is already formed should conjunct with your new neurons and develop a new skill for you, a new competency. So, and we also outline the role of cyber patient in this, because right now all 4 stages of transfer occurs where? In the clinic with patients, which brings a lot of ethical and legal issues, and it slows down the educational process. So what cyber patient brings to the medical community is to have all first 3 stages, which would include the orientation to fine tuning. All these 3 stages can be done in a virtual environment without harming a patient. While then, when the students are ready for practice, then they can go into the routinization or mastery with real patient. So I don't want to talk about the details of that. We also talked about other philosophical approaches and theories behind learning, particularly the theory of learning, experiential learning, learning by doing, the style of learning, the adult theory of learning, which we called it andragogy, and in relation to pedagogy, because pedagogy is mostly ped is child, in Latin, so pedagogy means leading the child. So what people are saying that when we are dealing with adults, we have to call that andragogy and leading the adults, because adults are learning different from children. And so in the end, I talked to you about the simulation in medical education, how important it is. In the oh, wait, it's not moving. Oh, sorry. Okay, I think I have to just. Oh, okay, now it's moving, right? Okay, somehow it was frozen, it was not moving. So in the second lecture, we talked about the curriculum development, how important curriculum is, how we can develop curriculum. Thanks. We talked a little bit in this lecture about the history of curriculum. You perhaps remember now where the word curriculum is coming from. Do you remember that? Yeah, the word curriculum is coming from ancient Greek games. To cur in Greek means to run. So when they did this chariots, when they run the chariots around the stadium, when they complete one round, then they called it curriculum. And only Babbitt in the 1800s brought that concept of curriculum into medical education. And now that's why, because in medical education, Babbitt thought it has to be a complete circle. You have to have a learning objectives and deliver your knowledge, and then you assess your education, and then you learn from your past, and you then connect back to the learning objectives and fix it every time you go around, you make it better and better. So, and also, if you remember, the Babbitt's, the most important part was that he revolutionized education as a whole, not medical education, because in the past, education was teacher-centered, and the teacher will come to the class and say what he wants and do what he wants, so he didn't have any obligations toward anything, and not even toward the students. So if he's tired, he will ask students, read yourself or sleep, everyone, or I'm going to sleep also. But when Babbitt came, he said, no, that the education should be structured, and it should have a learning objective. And in the end, students should be assessed for that learning objective. So we talked about all that, and we thought about the components of the curriculum, the modern components of the curriculum, which includes needs assessment, and then learning objectives, and then the materials, the processes, to go methodologies, and then assessment, evaluation, and reconnection back. So that's the modern curriculum components. So how to do curriculum design, we also talked about a lot of things. I don't want to take much of your time from questions and answers, but if you remember, I took it back to the time of Aristotle, and from there, we have a different type of learning that I described for you, okay? Based on understanding of Aristotle, how knowledge is, or what knowledge is. So in the fourth, then we talked about the gamification and identified main elements of gamification. We talked about gamification, medical education, and how careful we should be to not too much gamify medical education, but to gamify it enough to support students, to motivate students. So at this point, I think I'm gonna stop, not repeating things again and again. Perhaps it would be boring for you if I do that. So I will ask now Saad to maybe give me some of the questions that students have already wrote in the past. So we can go through those questions first, and then we will open the floor for others to ask their own questions. Is that a good
Perfect.
process?
Perfect.
Okay, please go ahead.
I'm just gonna get back to the first episode where we talked about the theories, also the history of behind education. And one question that was asked both by educators and learners is how we define and how we detect what's the preferred learning style. How can we ensure that either as a student or as educators, we can define learning styles?
Yeah, the issue of the learning style is a very complex issue because in the 80s and 70s, people tried very hard to see who is a conversion and diversion and how to put those people into the classroom. But it's very difficult because people may in one group, you may have people with variety of style of learning. Perhaps considering a style of learning is much better in apprenticeship model when you teach one-to-one. However, if you remember, there was a neuroscientific theory of Fleming I described. Well, that is much more important with respect to style of learning for people to implement in their curriculum. So what Fleming was saying is that people don't have one type of memory; they have several type of memory. People have visual memory. Some people have more audio memory. Some people have more tactile memory. Some people have reading memory, some people have writing memory. So when you're designing your curriculum, it's important that you deliver your subject in a way that would include most of the memories. It would trigger most of the memories. If you just rely on reading a book, maybe 80% of your students will fail. But if you rely only on lecture, maybe another 20% would fail. But if you have pictures, videos, lectures, and then ask him to write, concentrate. Like in cyber patient, we're insisting that every student should write their findings in the chart. Because when you're writing, you're conceptualizing, and in writing it down, then you remember it forever. Does that make sense?
Yes. Thank you, Dr. Qayumi. If I may just summarize, I think what's important here is to go from the idea that we should target like one learning style to idea that we should diversify to be able to just fulfill and to adapt to our audience of students, is to make sure that we cover all learning styles and also memory to make sure that we cover like the diversity in our students.
Yeah, and here there is also another important part, in that is the how Gardner's theory of multiple intelligences. Howard Gardner, a Harvard professor, wrote a very good book that I would recommend everybody to read it. And it's about, the book is called Frame of Mind. What he is saying in this book is that we are born not stupid. Everybody is born with some sort of an intelligence. Some people have, mathematical intelligence, logical mathematical intelligence. Some people has writing, reading intelligence. Some people have kinesthetic intelligence. Some people has interpersonal intelligence. Some people has interpersonal intelligence. So he divides a lot of intelligences. So what he meant is that in our school system, even in undergraduate, even K to 12 schools, we rely on logical mathematical intelligence. Even all the, if you want to test your intelligence, the test is also based on logical mathematical. But what our Gardner is saying that people may be born with kinetic intelligence that could be the best athlete, the best dancer, could be talented in some other ways. Some people will have interpersonal intelligence that will become the best journalist, the best movie star. Some people will have, so we can't just label people stupid or them because they don't have a higher level of logical mathematical intelligence. Those people might have some other intelligences. And what our Gardner is saying that from the childhood, we should identify those intelligences and support them through school, university to gain what they are intelligent in.
Thank you very much for these wonderful insights. The second question that was requested by our dear audience is, how do you think and why is competency-based education promoting excellence, especially in like healthcare settings?
Well, in the past, we emphasized a lot on scientific theories. And medical students, including myself at that time, we were reading and reading and reading things that are way beyond imagination. But then people came lately to the conclusion that whatever science out there is, it's impossible for us, for one person, for a medical doctor to read them all and understand them all. Why don't we confine that to specific to the things that we do in medicine as a doctor, as a nurse, as a respirologist? Because in a way, medicine is a trade. Okay? It's not a philosophy, it's a trade. So in every trade, you need competencies. You have to be competent on doing what you do. So that's why they bring competency-based education, so that when you finish medical school, we expect you to have like 180 competencies, and they don't do list. So I know from my back from my days, we had students in my class who were like top student every year after year, and they finish with in Russia I was given that with red degree. They call it red degree. So they got red degree. When they went to medical practice, they failed. So they come back to the Department of Anatomy or with somewhere else. Why they failed is because they were very good at theory, but they didn't know how to do things. They didn't have this. So what we are trying to do now here is to make sure that a doctor that graduates actually can do things that was expected from him. And he should have scientific-based, evidence-based knowledge around that competency. not around something else. If somebody is going to come here and give me a lecture on biochemistry about a molecule or a submolecule or a piece of a electron or positron moving somewhere, and he's done 3 years of work to do his PhD on that molecule, and he comes and talks to me about it, I don't know how it relates to me when I go to the office, right? And I see a patient coughing or having a high blood pressure. So that's why I think the competency-based education is now in fashion, and it's very important so that we can make doctors that can practice, that can do things.
Thank you very much, Dr. Qayumi. I'm just going to go to the third episode talking about curricular design. I want to know what's like the basis when we want to assess what's needed in a curriculum. I think this question was asked by a faculty member.
Sorry, I couldn't get that. About the assessment or about the curriculum development?
About the assessment that would be like before or like prior to a curriculum development.
So maybe I guess it's a little bit confusing, but he maybe thinks about the needs assessment before curriculum development. Okay, that's it. So I think it's a very valid question. We should all do a needs assessment before any medical program. Nevertheless, there are medical programs and medical schools that has been around for a long time, and historically they become gold standards of medical education. Those programs, they do not need a needs assessment. If a program is already part of a medical school curriculum, the assumption there is that the needs assessment was done. Okay. However, if you make a new program or a new class, then you have to do a needs assessment to see if people like this, if there is a need for that. I give you an example. In my lifetime, many students came to me and they said, "Oh, Dr. Qayumi," when I was practicing medicine, was Dr. Qayumi, we need to know a little bit of topographical anatomy. Because when I was doing surgery, I was telling them, now we're going to see this, now we're going to see that. And they would say, how do you know that? And I say, well, I know topographical anatomy. So in medical schools here, they don't do topographical anatomy. So, but where I studied in Ukraine, we did topographical anatomy. So, and then they said, well, could you please do a course of topographical anatomy for us? I said, sure. And I went to the head of the department and to the dean, and we did a survey. We asked all medical school students, do you need topographic anatomy? Why this topographic anatomy would be good for you? And then we, based on that needs assessment, we find out that only students who go to surgery likes to do topographical anatomy. The others, they don't care. So we made them customize a course of a month rotation in conjunction with the Department of Surgery and Department of Anatomy that had learning objectives based on that needs assessment and so on and so forth, in assessment criteria in the end. So the long answer to make it short, the curricula that is already in medical schools, they have been validated somehow, and in the need assessment is not needed there. But if you develop a new curriculum, it's utmost important to do a needs assessment.
Perfect. Thank you very much. I think the message here is that it's also about awareness and this connection between faculty members and students that would allow them to detect this kind of needs and to be able then to assess the needs in like more like methodological methods, like by surveys or other means, to be able basically to answer to like this need. And your anatomy example is a great sorry about this. Yeah, like going to another question.
Let me, before we go to another question, let me give you another good example. Like technology, introduction of technology to medicine. The online technology, the medical technology, everything. So, I mean, the huge invasion of technology into medicine. However, we don't have any subject of understanding learning technology in medical schools. So lately, we talked about this with our dean in our medical school. What about if we are going to introduce them? And for that, we need a needs assessment to understand if they need this, and if they need it, what are the important things that they would like to learn? If they want to be, technologically savvy, what are the most important things to do? The operating systems, coding systems, analyzing systems, how a system would be integrated to my education, how my education related to technology. So those kind of things, those are the details that you can do in your survey. Sorry to interrupt you. Yeah, go ahead, please.
Perfect. Yeah, like I just want to add the next question on, as we are talking about the curriculum development. And there was a question about how do you suggest we can incorporate soft skills into the medical curriculum? As we know, there's different curricula, and like what's seen is that some schools, they only focus on the scientific, and as you said previously, like once we go to the clinic, once you go to the hospital, there's a lack in soft skills training. So how do you suggest we can implement this in our medical curriculum?
It's a very important question and very good question. I would like to take my hat for this student or faculty who asked this question. I think soft skills are not very much taught in medical schools. Although we do some bedside teachings, we do some how to deliver the bad news, how to talk to. So professionalism, it covers mostly professionalism. But the biggest soft skills that is missed in medical curriculum all over the world, not just in North America, all over the world, is communication skills between different professionals. You see, as I always said, from my perspective, there are two gaps in medical education. One is the gap between theory and practice that we bridge it with cyber patient, right? So the other big gap in medical education is individual training and credentialing, and then teamwork in the hospital. So I, as a doctor, individually trained, and nurses are trained individually, and respirologists, social workers, whoever. But when we come around the trauma patient in an emergency room, we have to all work cohesively as a team. But we never worked as a team before. So we don't know, right? So we don't have any soft skills in this relationship. So that's the time, that is the part that universities don't do anything. Lately, some universities using mannequins, they develop these soft skills. So if your university has the mannequins, ask your teachers to develop cases, trauma cases, emergency cases for the development of soft skills, and they can do a teamwork around a mannequin, and then go afterward for what we call it debriefing, right? But the good news, but it's very expensive, particularly if this person who's asking this is from developing nations. it's extremely difficult because those mannequins are a good mannequin is a $500,000, and you need another $500,000 to implement that, and then you need manpower to run it. A smaller even one is $60,000, and also to run it and everything is going to be like into close to $500,000. And you can do only one or two classes a day. But the good news for you, for all of you, is that we at Interactive Health International are in the process of completing a patented new product that is that's going to help you with your soft skills, with not going even out of your home and not being even paying anything for it. So what we develop right now is a patient avatar in the virtual space, and also 5-6 team avatars that will work with the mannequin. And then these avatars will be controlled by an individual from outside, from anywhere. The nurse could be in the Arabia, and the doctor could be in North America, and the social worker could be in Brazil. So it doesn't matter where you are, and all communicating with each other on this platform in a virtual environment. And then the session is actually recorded, and then after you take this recording and virtually, like now, you sit in a meeting room and discuss what went wrong and what we should do, and who didn't respond to whom, and how do we move our soft skills. So that is that's the good news that I'm bringing it for you. But you're absolutely right. If this crew resource management and soft skill training with simulation did not happen in aircrafts, airplane industry, the world is would not have been the same place. Because in the 60s, 50% of the airplanes that went up, they fall down. And now it is 0.01% is falling down.
Yeah, thank you, Dr. Qayumi, about this. You just reminded me when you talked about collaboration, about one of the best conferences I've been to, and the professor was talking about the anesthesiologist surgeon relationship and how it impacts. And you as a surgeon, I'm sure you have a lot of long stories about this relationship in the operating room, and how it impacts the patient outcomes, how it impacts also a lot of different points. And there is a lot of literature also in this field about how communication between the surgeon and the anesthesiologist is important.
Well, I'm not going to make any comment on that. Surgeons and anesthesiologists are good friends. So let's put it this way. They have no choice. They have to work together. But I think there are a lot of conflicts because of not being trained. But it's not just between the surgeon and anesthesiologist. It's between the surgeon and anesthesiologist and the anesthetist and the technologies that run the pump, the nurses. The nurses have always conflict, and then there are different type of nurses, right? The scrub nurses dynamic in the OR is another area of the training of soft skills, and that's what we're going to do. And I have to tell you, in the OR, we did a study a few years ago. The women are in disadvantage. It's actually the OR itself is prejudiced to women. The environment is prejudiced to women, although most women works in the OR, right? But if you have a woman doctor, because all the table, the instruments, everything in the OR is made for a 6 foot tall, strong man. So now can you imagine a small little petite but very smart woman comes to the OR? She would have problems. The first thing she would ask, can somebody bring me a pedestal? And you'll see even the nurses doesn't like that. Now she's gonna call another pedestal. And then to open and close those clamps, for me it's easy, but with tiny hands, it's not made for her hands. So, and then she has difficulties, and then everybody will laugh, and everybody will say, nasty things, not in front, but in the back. And so these things are always there, but I think it's getting better and better every day. Every day we understand this. We make publications about this. We make people aware of this. The racial issues, in the OR is also huge. Diversity and inclusion. These are the things that we can do through education only. Through education and through education, competency-based education, where you simulate things and make sure that they understand, if it would happen to them, it would be not good. So yeah, sorry, we just talked about OR.
Thank you very much. I'm just gonna go to the next question, and this is more about the gamification. And the question reads, how can we implement gamification in low and middle income countries where maybe some kind of technology is really hard to obtain?
I think gamification doesn't make the education more expensive. So this is a myth. This is not true. Like cyber patient, we have cyber patient. It's a gamified platform. We can make it, if you want to make it more gamified. What we do is just put a bulletin board up there and list and make a competition for different universities, for different countries, for the whole world. So we can be the Olympic of cyber patient. It's not going to change anything for developing nations. But what the problem with developing nations that I'm trying to solve is the bandwidth. The biggest problem is the bandwidth. So the second problem is the equipment, because in developing nations, the rich kids would have the computers, and the poor kids would not have computers. The rich kids would have at home a high band internet. The poor kids would not have that. So when I go to Africa and to other places with the developing nations, that's what I say. I say, unless I have the opportunity to equalize education in the country, I'm not going to give it to you. So what we make a decision is that then we don't want to punish rich people either. They have money to do that. We want to take care of the poor people so that they can have it. So wherever I go, now with my Canhealth International non-for-profit organization, we're raising a lot of funds to actually build electronic libraries for poor kids, so that it could be 24/7 open, and then they can come and study with a very high bandwidth without any charge. So the problem of the internet is not just for cyber patient and medicine, it's for the whole thing, because the internet, people in the beginning thought that the internet would equalize. We deliver knowledge to the poor countries, but they don't know that the internet in poor countries make the poor poorer and the rich richer. So we take care of that.
Thank you very much, Dr. Qayumi. I'm just gonna take the opportunity to invite our students and our faculty attending to share their question either on the chat or the question box. We'll be really happy to read your question, especially if it covers these topics.
they may also ask the question if they can ask the microphone, just say, open your microphone and ask.
Yeah, actually, like they can ask and we can allow them to open the microphone, and it would be good to hear directly from them. We already have one question. Thank you very much, Mr. Kennedy. The question reads, what can you comment about e-learning implementation for medical courses, especially in Africa?
I think e-learning has a very large connotation. So e-learning in relation to delivering content in texts and videos, animation, things is going to be very easy. So with any kind of bandwidth, you can do that. But complicated platforms such as cyber patient platform creates problems because there is no bandwidth there. And we are now, with respect to cyber patient platform that I'm responsible for, we are looking into a solution that we would create a local area of network in a university where we sign a contract. Like in Ethiopia, we have contract with 37 universities in Ethiopia, in Sudan, in Nepal, we have in Iran, we have all over the world. So we would like to do one of the two versions, a local area of network or a desktop version, so that we can bring cyber patient into the desktop so the student can use it without any problems. But we are working on this. Perhaps in 1.5 years, we're going to be able to come up with that solution. But at this time, e-learning is very important, I would say. Every university should, even in the developing nations, should go to the United Nations, to the charitable organizations, to make an auditorium in an electronic library with a high bandwidth that would support e-education. So I believe, I know that in some countries, I'm giving an example of my own original country. I'm originally, for everybody to know, I'm originally from Afghanistan. And I know that some students are studying with notes of a professor that was done like 20 years ago. I mean, that is way, behind imagination, to learn medicine from a notes of a professor that was written 20 years ago. It was not updated ever. So e-learning would bring all this opportunity for you that opens the knowledge from all over the world to come to you. You go to the YouTube only, you can see anything. My son is calling himself a Google doctor. Mm-hmm. So you can find anything in the internet. And I think there is lots of good information. So it's important to have. And also for universities, every university has a learning management system, and the learning management system has the electronic content to deliver.
We also have like a second question related to the same subject. With now technology on the rise and like learning management systems are being adopted by different universities, what is your view on the number of hours and the ratio in like the online versus face-to-face learning?
I think there is a huge debate on the online versus face-to-face, what's more effective, what's needed and what's not needed. And there are proponents of both sides arguing it. But I think this COVID-19 have shown us that, first of all, virtual environment should not be ignored. It showed us that e-learning can be done properly and good. But it also showed that you cannot 100% rely on e-learning. You have to have your face-to-face. So I think within the next 5 to 10 years, in my opinion, we're going to have a much better education system that is hybrid, combining the virtual with face-to-face. So in medical education, particularly when it comes to clinical skills, nothing would replace a human being, a patient. But we can have technology to prepare them better when they meet the patient.
I'm just taking a question about this screen-based simulation. What do you think, and this is like a challenging question, what are the constraints of screen-based simulation over the simulation used in physical simulators, for example?
Okay. Well, I would say that screen simulation has its own merit, and physical simulation has its own merit. As I mentioned, screen simulation does not replace lecture, does not replace physical simulation, does not replace a real patient. It's an additional tool to support your education. Let me tell you the difference. The difference is that, first of all, in the cost. If you have physical simulation, the higher the fancier the equipment is, the more you pay for it, right? The higher the fidelity of the equipment, the more you pay for it. Physical simulation is confined in space and time. So you have to leave your space and go to that space to do studying. For students, it may not make much of a difference because they're coming from one class to another class. But for nurses who are working in the hospital, when they come to the simulation lab, the hospital have to pay somebody to do her job and to pay her to come and do simulation, physical simulation. Okay, so so those are perhaps the constraints, and you cannot do the continuum of care with physical simulation. With physical simulation, you can do a specific tasks, like I do laparoscopy, suturing technique. I do Euro mentor or GI mentor, or do a case of acute abdomen so you can do all those things, but you cannot do something that there is no laboratories out there, as far as I know, that you can go to into a hospital, see a patient, talk to the patient, take history, do physical examination, order everything you want, which is in the hospital, all the laboratories, findings, and then make a conclusion, and then you go and make decisions whether you want to keep this patient in the hospital or going to send it home, and in the way, what kind of medication you gave to it, and so on and so forth. So you cannot do this with mannequin, or with any mannequin, ever. And also, when you do it with mannequin, you need a technologist to be beside you and a teacher to be beside you to assess you. With online simulation, you have an intelligent tutoring system, an artificial intelligence that goes behind and picks up all your problems, and in the end, it gives your problems back to you, so that next time you do better decisions. So in short words, because we don't have much time, these are perhaps the most perhaps biggest differences between a virtual simulation and a physical simulation. I hope I answered the question to my colleague.
Yeah, Thank you very much, Dr. Qayumi. I'm just taking the final question, and this time the honor will be for Shaya, a member of our clinical club, like our community of remarkable students from worldwide. And the question reads, do you have any resources or books or that you can share with us that are good to learn how to use as effectively as possible gamification in curriculum development?
Uh, Unfortunately, there is no one book that I can tell you. It's scattered all over, but I think it's mostly in the side of educational psychology rather than medicine. I think if you just go to the internet and just say competency-based education and or curriculum development, you have a lot of information. But unfortunately, those informations are very much scattered. And the books are totally confused. So I would say, yes, you can gain that experience by being part of the cyber patient club. I could, if you are part of the cyber patient club. If not, please join, and I will make sure that as soon as I find good references, I will send it to you so that you will have it.
Thank you very much, Dr. Qayumi. I don't know if you have any final comments, but we are arriving to the end of this amazing session. As we promised you in the first episode, we wanted to have this session to make sure that all your questions were addressed, and we were really happy to meet you again today. Thank you, Dr. Qayumi, for sharing your expertise and wisdom again, and your amazing stories and expertise. Thank you all who have joined us today. As previously said, the recordings of the episode are available to our registrants. And please, if you have any problem like viewing the recording, please feel free to reach out to us. We will be really happy to help you. Thank you again.